Good afternoon. So I have been asked to speak about US liver biopsy, the right candidate selection. Liver biopsy, as you all know, can be done for focal liver lesions as well as for diffuse parenchymal liver disease. In diffuse parenchymal liver disease, it helps to clarify a diagnosis, determine the severity, predict prognosis, inform treatment decisions, monitor the disease progression, and obtain tissue for other methods for investigations like microbiology or biochemical. The liver biopsy, as it was alluded to earlier, the first was reported in 1800s, and then in 1950s, with Menkini reporting a 1-second biopsy, it came into prominence. And then the transjugular liver biopsy in 1970s, and then laparoscopic biopsies, and the latest kid on the block is the US guided liver biopsy. The biopsy was first reported earlier, but the major good tissue was obtained in 2007 by Matthew, who reported this. So this was one of the larger series during this period. That was in 2009, and it was mentioned in a clinical endoscopy, the new methods of GI endoscopy. And the editorial talked about US-guided liver biopsy, a procedure looking for an indication. So after 15 years, now we are again talking about the indication for US-guided liver biopsy. So when you do a liver biopsy, there are certain benchmarks for an adequacy of the tissue. Remember, we are taking out 1 in 50,000 of the tissue while doing a liver biopsy. The most recommendations say that a total specimen length has to be between 15 to 20 millimeter, and the adequacy of portal tract 6 to 10. In 2009, ASLD mentioned that an ideal length should be about 3 centimeters after formalin fixation. So after formalin fixation, actually it shrinks by about 1 millimeter. And the tissue has to be taken with a 16 gauge needle. So in EUS, the largest needle is about 19 gauge. So the latest guidelines in 2020 mentioned that by a multi-society guideline, that the length of the sample should be at least 20 millimeter and the portal tract of at least 10 millimeter. So why is it so? Why are we talking about the length of the tissue? So it has been shown by an elegant study which was done in 2003 that if you have a reduction in length and also the reduction in the size or the diameter, then you underestimate the grade and stage of the tissue. So shorter the sample, higher the rate of mild grade and fibrosis. So you will tend to say that it is a mild type of disease or inflammation. So you need to have an adequate tissue. So why should one be considering US-guided liver biopsy at all? There are certain potential advantages because you can see, you have the ability to view both the lobes of liver and can biopsy from the right as well as from the left. A real-time assessment of the procedure is there, so you can avoid vessels, see whether there is any bleeding or not. And this is usually done under sedation, so there is less apprehension and less pain during the procedure. And it can be done in obese patients if they are fit for anesthesia or deep sedation. And also concomitant upper G endoscopy, EUS assessment, and also even now US portal pressure measurement can be done along with it. So during upper G endoscopy, you can assess the varices or whether there are dyspeptic symptoms, you can look at it. On EUS, you can assess the biliary system, the pancreas, look for any subepithelial lesions if it was already mentioned, and also portal pressure gradient. So what are the indications for US-guided liver biopsy? So any patient who requires a liver biopsy is also an indication for US-guided liver biopsy, provided the patient should be able to undergo moderate sedation, A non-cirrhotic or requirement for pressure, measurement of portal pressure that has not become a standard of care, so choice now. But one should also understand that when you do biopsy in these patients with cirrhosis, the chance of getting a core full-length tissue is less. There can be splitting of the tissue. Specific situations where US-guided liver biopsy may be preferred, or a requirement for sedated liver biopsy, pediatric liver biopsy, or a concomitant need for endoscopic procedure, or when you need a bilobar biopsy. There are contraindications as for any other percutaneous biopsy, coagulopathy, or uninterruptible use of anticoagulants, large amount of ascites, or if you are suspecting amyloidosis. The disadvantage is that you should have an experienced endosonographer, and it is more costly, and procedure duration is longer. So when you do an US-guided liver biopsy, first you need to select the needle, prepare the needle. So most of the time we are doing a wet suction. So you have to push take out the stylet, push the lumen with about 3 ml of heparin flush, and then after that, into the syringe you take about 2 ml of saline, and then with the suction you target the tissue. So you have to target a tissue where there is no intervening vessels, and you have at least about 3 centimeters to go deep into the tissue. And one puncture, maybe at least 3 actuations would be good enough, can have more if needed, and the specimen should be retrieved in a sieve. During this time, you should flush so that all this blood can be removed. So this is a patient where we are doing a left lobe liver biopsy. You first put on the Doppler, see whether there are intervening vessels, and after that, you puncture with the needle at least about 3 centimeters into the liver parenchyma, and then you do at least 3 actuations, and you can go into the different areas. And after that, you put on the Doppler, and this is definitely, when you take out the needle, you should see whether the Doppler is trailing you or needle or not. If it is trailing, just keep the needle there for some time. Most of the time, it will go off. If not, if you see that the bleeding is still there after a minute, then you push the tissue into the tract. You might lose a little bit of tissue, but at the same time, you can prevent a bleed. So this is a kind of tissue you can get after a US liver biopsy. So the initial studies were on US-guided FNA needle. It was shown that the complete portal tracts and the total length of tissue was equivalent or better compared to the percutaneous liver biopsy. And in the earlier studies, excluded cirrhotic patients because the fragmentation was more in this. Is it safe or is it effective? The first meta-analysis in 2019 included 9 study arms with 437 patients. The pooled rate of success was about 93.9%, and pooled rate of adverse events was only 2.3%, and calculated rate of bleeding was about 1.2%. So this was an outlier study in 2021 published by Bang et al. In Gut. So here they looked at percutaneous liver biopsy versus US-guided liver biopsy, 40 patients, and they found that the percutaneous liver biopsy yielded more tissue, and the cost was much higher in US-guided. However, the pain score was less. So they concluded that the radiology-guided percutaneous approach is superior. However, it was criticized because they say it was underpowered, there was no suction which was used, and the optimal tissue was got only in 57.9% of the percutaneous liver biopsies. So whether it is single actuation or 3 actuation, in this study it was found that 3 actuations give you more tissue, more complete trial. So wet suction versus dry suction, even wet suction gives you better tissue, and because you can clear the clots formation. And slow pull technique has also been found to have almost equivalent result as a wet suction technique. So what about bilobar biopsy? So especially in certain conditions like non-alcoholic fatty liver disease or metabolic dysfunction associated fatty liver disease, the involvement can be patchy. So in such situation, it can be different. So this study looked at that. The coefficient of agreement was good for steatosis and ballooning, but it was not for inflammation and fibrosis. So it can be different in both the left and the right lobes. So only right lobe assessment or a left lobe assessment underestimated either fibrosis or inflammation. So whether 19 gauge or versus 22 gauge, it was found that 19 gauge was better. This was, and 19 gauge aspiration needle versus 19 gauge core biopsy needle. Again, 19 gauge core biopsy is much better. So what about fork tip or Francine needle? Francine needle was supposed to be better than a fork tip needle. So US guided liver biopsy, that is a biopsy needle, core biopsy needle is better than a percutaneous liver biopsy or transtubular liver biopsy in this particular study. So in the meta-analysis, it was found that overall diagnostic accuracy was equivalent to a percutaneous liver biopsy, and the odds ratio was also similar when you combine only randomized control trial. The mean portal triad was higher in the percutaneous biopsy, but it was not statistically significant. The adverse events are similar between percutaneous liver biopsy versus transtubular liver biopsy and US liver biopsy. So the adverse events as such, it doesn't have much difference. And the bleed can be subcapsular hematoma or intraperitoneal bleed. And pain during the procedure is not there, but post-procedure sometimes it can be there and these patients might require analgesics. Less pain and during the procedure, so this is what was seen in this particular study. So we use liver biopsy as good efficacy and safety profile. Single pass with at least 3 actuation is better. 19 gauge better than 22 gauge. Francine needle with wet suction method is preferred. Maybe a slow pull also would give you equivalent result. So which patient should be considered for US liver biopsy? So if you are doing an endoscopy with other concomitant endoscopy procedure and you want to do a liver biopsy, of course this is a good method. If it's an apprehensive patient and if an earlier percutaneous liver biopsy had failed to obtain good tissue, this is a good choice in such a situation. Obese patient with difficulty in percutaneous method, and if it is patient who is fit, then you can do this. When both lobe biopsies are required, especially for metabolic dysfunction related liver disease, then possibly this is a good choice. Thank you.